Managing Elevated Lipoprotein A in the Statin-Treated Patient by Dr. Sina Rafath. Welcome everyone to this high-end medical explainer. Today, we're kicking off a really cinematic visual journey into advanced cardiovascular risk management. For decades, cardiology has basically been locked onto one primary target. But as medical science evolves, we're starting to map out a hidden danger, one that literally lurks in the bloodstream of millions, and we'll be decoding the cutting-edge therapies that are straight up rewriting the future of heart health.
So let's dive right into this clinical mystery by posing a critical question, one that honestly haunts modern cardiology. Imagine you've got a patient who does absolutely everything right. They take their prescribed statins, their standard LDL cholesterol, the famous bad cholesterol, plummets down to perfectly optimal levels, and yet their risk for a heart attack or stroke remains stubbornly, dangerously high. Why? Why does this cardiovascular risk persist when the main target is perfectly lowered? Well, to answer that, we have to look past what the statin is fixing and focus intently on what the statin is entirely missing.
And that brings us face to face with a fascinating and frankly alarming clinical phenomenon. We call it the statin-Lp paradox. Now, we all know statins are miraculously effective at reducing standard LDL. But when we look at their effect on lipoprotein A, or Lpa for short, we see a staggering contrast. Statins literally have a 0% reduction effect on it. Zero. In fact, clinical data actually reveals they might even induce a modest increase in Lpa levels, bumping them up by as much as 1.1 milligrams per deciliter. So what this means is, as you lower the LDL, the Lpa becomes this much stronger, unmasked predictor of residual cardiovascular risk.
Let's meticulously map out the clinical thresholds of this hidden threat. Like, when exactly does Lpa shift from just being a background particle to a really active danger? Well, the critical baseline threshold we're looking at is 50 milligrams per deciliter, which translates to roughly 125 nanomoles per liter. This specific number marks the point of elevated risk. And what's truly sobering about this metric, its sheer prevalence. This isn't some super rare anomaly. It directly affects a massive 20% of the population. That's 1 in 5 people. And for those folks, hitting that 50 milligram mark confers a 40% higher relative risk of atherosclerotic cardiovascular disease.
Now, what's really interesting here is how aggressively the stakes escalate the higher those numbers go. This isn't just a flat line. It's a very dynamic dose-response relationship. While 50 milligrams per deciliter puts a patient right in the elevated danger zone, just think about what happens as the concentration rises. Between 80 and 100 milligrams per deciliter, the patient's baseline cardiovascular risk completely doubled. And if those levels keep climbing and hit the 180 milligram mark, or around 430 nanomoles per liter, that risk actually quadruples. It's a steep, unforgiving climb that absolutely demands immediate clinical attention. And this brilliantly illustrates the absolute highest clinical risk we see, a hazard ratio of 1.90. This peak danger is observed when a patient suffers from a truly deadly combination: elevated Lpa paired with high residual LDL cholesterol. Basically, this means the patient is facing nearly double the risk of a severe cardiovascular event compared to someone without these compounded factors. This precise data point hits the nail on the head as to why the statin-Lpa paradox is so absolutely crucial. If the statin isn't getting that standard LDL low enough and the Lpa stays high, the patient is basically caught in a compounding crossfire of cardiovascular risk. Transitioning now from the threat to our tactical response. Section 1, the blueprint. Here is our clinical management roadmap. Let's see how this builds into a strict, highly sequential 3-step clinical roadmap. Step 1 is where we draw our absolute first line of defense: early risk factor intensification. See, because we can't easily lower the Lpa right out of the gate, we've got to aggressively optimize every single other modifiable risk. We're talking intensive control of blood pressure, strict glycemic management, and serious lifestyle modifications to offset all of that non-modifiable risk. Then step 2 demands a high-intensity statin baseline. Even though we know it doesn't lower Lpa, we absolutely must continue maximally tolerated statin therapy to guarantee those primary LDL goals are locked down. After that, we reach step 3. Sequential non-statin addition. So the really crucial point in step 3 is how we safely escalate things. If those standard LDL or ApoB goals remain unachieved on statins alone, we don't just immediately jump to the most complex therapies. No way. Instead, we sequentially add specific, targeted oral agents. We bring in medications like ezetimibe or bempedoic acid. These drugs work through entirely different mechanisms than statins to essentially pull more cholesterol right out of the blood. It's a very calculated, systematic layering of defenses to push that overall cardiovascular risk profile as low as medically possible, long before we ever consider escalating to advanced biologicals. Entering the specialized arsenal phase of our explainer. Section 2, the arsenal. Specialized and emerging therapies. Let's survey the advanced weapons we currently have at our disposal. Grounding ourselves directly in Dr. Rafit's clinical mapping, our first line of advanced defense is PCSK9 inhibitors. For patients with established cardiovascular disease who have an LPA of 50 milligrams per deciliter or higher and are still not at their LDL goal, these injectable biologicals are the preferred Class 1 add-on recommendation. And why is that? It's because of their incredible dual action. Not only do they drastically slash LDL, but they actually offer the strongest LPA lowering among our current FDA-approved agents. Looking at the variations in efficacy, evolocumab can pull LPA down by an impressive 27 to 47%, while alirocumab yields a really solid 18 to 26% reduction. Now, there is a totally fascinating exception here within the clinical guidelines, aptly named the controlled LDL exception. Usually, PCSK9 inhibitors are reserved strictly for those who just cannot get their standard LDL down. But for a patient who has recently suffered an acute coronary syndrome, like say a sudden heart attack, the rules completely shift. These high-risk, recent event patients can actually derive significant life-saving benefit from these dual-action inhibitors, even if their standard LDL is already highly controlled near 70 milligrams per deciliter, and their LPA is only mildly elevated. It really just proves that in the wake of an acute event, targeting even a slight LPA elevation with powerful biologicals is a vital defensive maneuver. Examining the intervention effectiveness with absolute lab precision, we can start to contrast our current standard of care against the absolute future of medicine. Statin therapy? It sits at a flat 0% reduction for LPA. Step up to PCSK9 inhibitors, and you achieve a respectable 15 to 30% reduction on average. But then, look at the experimental frontier. siRNA therapies. These are capable of a staggering 80 to 95% reduction. I mean, that is a massive quantum leap in therapeutic efficacy. It shifts us from merely managing a threat to virtually neutralizing it altogether. But what do we actually do today for the most severe, high-risk cases while we're waiting for those experimental drugs to hit the market? Well, for immediate specialized intervention, we deploy heavy artillery, known as lipoprotein apheresis. Think of this kind of like dialysis, but specifically engineered for cholesterol. It's an FDA-approved physical filtration of the blood. It's reserved for patients with LPA levels at or above 60 milligrams per deciliter, combined with familial hypercholesterolemia or established coronary or peripheral artery disease. This intensive biweekly physical treatment can acutely slash LPA levels by 50 to 85%. It literally pulls the danger right out of the patient's bloodstream. Looking toward the horizon of medical science, we have to explore the cutting-edge Phase 3 trials that are quite frankly about to change everything. We are talking about emerging RNA-based therapies. Drugs like pelacarsen, which is an antisense therapy, and olpasiran, an siRNA therapy. These don't just filter the blood, they go straight to the genetic source. They intercept the specific messenger RNA in the liver, effectively telling the body to just stop manufacturing the lipoprotein A particle altogether. This exact mechanism is how we are achieving those unprecedented 80 to 95% reduction rates in late-stage trials. So we have mapped out the paradox where perfectly managed LDL still leaves patients incredibly vulnerable. We've charted the escalating risks and walked through our current clinical roadmap. But as we conclude our visual explainer journey today, I want to leave you with a final provocative thought. As these revolutionary RNA-based therapies move from clinical trials into widespread hospital use, how will these emerging treatments, capable of an unprecedented 80 to 95% reduction, permanently alter the global landscape of cardiovascular disease? Because honestly, when we can effectively switch off the genetic production of this hidden risk factor, we aren't just treating heart disease anymore. We're fundamentally rewriting the clinical roadmap for it. Thank you so much for joining me on this explainer, and definitely keep your eyes on this rapidly evolving frontier of medicine.